So lung nodules has become a big problem, mainly because the majority of them are missed on follow-up visits, which is a problem. So it's been estimated now for many years that we probably detect in the United States about 1.6 or more million new nodules every year. And we know that up to 5% of those nodules can be lung cancer. So what's the problem is that 60% of these nodules are missed on or are not followed up adequately. We published a study in 2019 showing that and patients who have commercial insurance, who have a claim of lung nodules in their insurance claim, have received absolutely no more tests in the 2 years after the nodule is detected, and 60% of the time. So if 5% of those nodules can be cancer, you can imagine where the problem is in terms of the dismal statistics of lung cancer, right? We know that 80+ % of lung cancer is diagnosed late, in late stages when you cannot cure it. So, we have all these lung nodules that are being detected incidentally. They're detected because patients get CT scans in the ED, or for whatever other reason, they're having a, a cardiac a cardiac angiogram, for instance, or or even a CT scan of the neck, and little nodules are being detected. If nothing is done about those nodules, we miss this opportunity to catch cancer early. And so that's what the background of the problem is. Many, many lung nodules, and unfortunately, they're not followed up adequately. So what we did now 2.5 years ago here at Mount Sinai is we set up an incidental lung nodule program using AI, particularly natural language processing, seeking or scanning all radiological reports from the system where there's a mention of a lung nodule. And it could be from anything from a chest x-ray, from spine CTs, abdominal CTs, lung CTs, obviously. Any radiological test that captures any part of the lung and that shows a lung nodule and the radiologist reports it, this software captures it and sends it to our dashboard and to our navigators. And we make sure that those nodules are not lost to follow-up. We have a complex process. We determine which patients need to be contacted, which don't. And at the end of the day, we're basically reducing the loss to follow-up from 60% that we were having prior to the nodule program implementation to 20% or less loss to follow-up. So, and we're capturing many, many lung cancers in early stages. So really, really successful program, and hopefully we're going to grow from here even more with new technologies. The most important presentation that we had was the summary of the first 2 years of the program. And what we described there is that we've scanned or detected reports, CT reports or X-ray reports with nodules in about 9,500 patients. Um, and after, the navigators, when they receive this information, they dig into the electronic medical record. They look for information on the patient. They determine whether the nodule is actually a nodule. Sometimes there's false positives. The radiologist maybe said in the report, nodule, and then 3 sentences later says not suspicious for lung cancer, more infection, whatever. So those are kind of, after reviewing that information, the patients are excluded from the program, but 2/3 of all the patients that we actually detect are included in the program. And after reviewing their EMRs, their electronic medical records, we divide the patients into two large groups. Those who actually have a plan in the electronic medical record for the evaluation of that nodule, meaning that the primary care physician or the provider already knew about the information and actually ordered a follow-up visit or a follow-up CT scan. We can see that in the electronic healthcare record. And in that case, we do not call those patients. We don't engage with those patients. We just track them to make sure that follow-up is completed. But then the majority of patients do not have a follow-up established, a pathway established, and we do engage with those patients. We call them. And what we found is that in those that we call, we diagnosed over 40 cancers, lung cancers. 75% of them were in stage 1 or 2 when they're curable. So prior to the implementation of the program, 60% of these were lost to follow-up, and now we're detecting them and we're catching them in early stage. So I think that's the main message from that presentation, that when we engage with patients, when we call them and tell them that they have a nodule, and we offer them the possibility of coming to the lung nodule clinic or to see a specialist in lung nodules, if they have a cancer, 75% of the time, it's going to be an early curable stage. That's the big message. The other presentation was on the complications. We detected 9,000 images with nodules, and I told you just now that we diagnosed 40 cancers when we called them. So there's a large group of patients who have a nodule and do not have cancer, and there's risk of causing harm in these patients if we start doing biopsies on every single nodule. And what we found is that we actually keep the procedures, the invasive procedures, to a very low rate, with the rate of complications once we do a procedure that is below 5% in the case of bronchoscopy and 20% in the case of a CT guided biopsy, in line with what has been published in the literature. So we're not causing excessive complications. And by following patients, by looking for growth of nodules, we avoid doing unnecessary invasive procedures. So we've been using natural language processing up to now, but we are, getting ready to jump into the next step into AI, right? To have several things. AI directly analyzing images, not the reports of the radiologist, but the images themselves, to help the radiologist detect the nodules and classify the nodules. But then using LLMs to actually research the electronic medical record and to take over a lot of what we are doing now with the navigators to research the charts of the patients, to find out their demographics, their risk factors, smoking, family history, and a lot more information that we extract from there. AI is going to be able to do that. So I think we're on the brink of a huge revolution in this field, and we're so happy to have this program already implemented, because it's going to be a big qualitative jump into being more efficient, detecting more nodules, and detecting more cancers in early stages. The results that we presented and the results of our program over 2 years really encourages me to stimulate and to spread the message to my colleagues that if you don't have a lung nodule program, an incidental lung nodule program, in addition to the lung cancer screening program that everybody should have, you should do it. Incidental lung nodule programs are detecting today lung cancers much more frequently than lung cancer screening programs, for several reasons. Number one, because lung cancer screening is implemented very poorly around the country. Less than 15%, 20% maybe max of people who are candidates for lung cancer screening are actually getting lung cancer screening. So incidental lung nodule programs are detecting, in some instances, and this has been published, 5 times more cancers than lung cancer screening programs. So I encourage everybody who is working in the field of lung nodules and diagnosis of lung cancer, that they consider implementing incidental lung nodule programs using these new AI tools that are becoming available.